entity, vulva, intraepithelial, neoplasm. So basically, the terminology, from my understanding, just like squamous cell carcinoma in the vulva area, but they are kind of different because we divide this VIN lesion into HPV associated and HPV independent VIN. And in HPV independent VIN, we also separate them. One is P53 mutation, the other one is P53 wild type. And then for the clinical issue is that HPV-related lesion happen like in younger patients, usually in 40 to 50, and HPV-independent VIN happen in older age, like 70 to 80. In the gross picture, we can see this raised plaque with irregular border in this vulvar area. And then this lesion usually associated with lichen sclerosis. So we can see this reddish irregular border area should be in the background of lichen sclerosis. And then this raised plaque area should be our VIN neoplasm. So for the microscopic feature, I think this one just like what we see in the cervix area, the whole epidermis full of these atypical pleomorphic hypercellular neoplasmic cell. So this is HPV-associated VIN. And then we also can see some of these virus-infected coilocytes here. Again, this is also HPV-associated VIN. We can see really pleomorphic hyperchromasia, and then mitotic active in terms of mitotic figure here, and then the full thickness of atypia from the basal cell layer to the spinal cell, granular layers, so all the epidermis of the squamous epithelium evolved by this atypical cell. See this really big guys. Then we have another entity that is HPV independent, but P53 mutation. So for this entity, we only see this atypical hyperchromasia pleomorphic cell just located in the basal cell layer. You can see mitotic figure, really pleomorphic, like ugly looking cell. But other than that, in other layer like the spinal layer, we can see this kind of eosinophilic cytoplasm, like this squamous cell just would like to mature, but not as pleomorphic and atypia as the basal cell layer. So this is a characteristic for the HPV-independent P53 mutation VIN. And then we also notice that in this papillary dermis, we can see really thickened collagen. So these lesions should be arrived in this lichen sclerosis background. Then again, we can see this P53 mutant VIN HPV independent one. We also can see in the basal cell layer, really pleomorphic, hyperchromatic in the basal cell layer, all of these. And then other than that, we can see this maturing epithelial squamous cell, no atypia, no pleomorphism. And then this one also shows this acantholisis pattern. And then the last entity is HPV independent and P53 wild type. So this one, you could not see significant atypia, including in the basal cell layer. All the cell just maybe larger and with this eosinophilic cytoplasm. The only feature of this one is the epidermis kind of thicker. So this acanthosis looking. We also have this perikeratosis. Again, for this one, HPV independent, P53 wild type, we could not see any atypia even in the basal cell layer. All the cells look the same and then not not really atypical. The feature we see just like thickening, hyperplasia of the epidermis, even in high power, the cell looks not atypical. And then for this entity, I think from one of the grand one, we have the recording. I think one of the guest speaker from University of Virginia, she has a really nice lecture about this VIN lesion. So if you're interested about this lesion, you can just go back to watch the video in our network. So for immunostaining, we all know if HPV related, we should have P16, strong, diffusely positive. And then we also have our P53 immunostaining. And then just bear in mind for this mutation pattern, we have overexpression. That means all of the neoplasmic cell have staining, strong staining by P53. But no, don't forget we also have this silence or new pattern. That means all of the cell, when we do P53, they loss of P53 staining. So basically, we use these two staining, we can tell whether this is HPV related and P53 mutation status. I think that's it for my lecture. Dr. Monica, do you have any